Hey folks, Matt here again with another video where today we're going to be talking about some airway adjuncts. In particular, we'll be looking at the NPA or the nasopharyngeal airway and the OPA or oropharyngeal airway. The basic purpose of this video is just to become familiar and review some of the basic features of these devices as well as some of the indications and possible contraindications to their use. So let's start by looking at the NPA first. The NPA, which is designed to be placed, of course, through the nose and displace some of the soft tissue with the purpose of really facilitating air passage through the pharynx and eventually down to the lower airways. But the NPA can also serve as a conduit for passing a fiber optic scope or even performing suctioning on your patient. Now, when we look at the anatomy of the NPA, there are just three basic components. The first is going to be the flange, which is the most proximal end here, and it's really just designed to rest against the nares and provide, or prevent, I should say, migration of the cannula into the airway. Then there's the cannula itself, the body of it, and then finally there's this beveled tip section here to facilitate passage of it. Interestingly, when we talk about the NPA, there are several different varieties out on the market. This is one standard size that is a one-piece device, but there's also ones like this other one I have here where the flange is adjustable, where I can actually move this up and down the catheter to size it and fit the patient that may need this device. So it's kind of interesting just to be familiar. There are a few different varieties out on the market, and these are just a couple examples of those. So I mentioned a little bit about sizing, and I just want to reiterate that we basically size the NPA from the tip of the nose to the patient's earlobe. And it's important to size it properly because these adjuncts, while they can improve airway patency, can also, if improperly sized, become an obstruction in and of themselves. Additionally, when we look at NPAs, we also want to consider contraindications, and that might include things like patients who are anticoagulated and at risk of epistaxis, patients with obstructed nasal passages, trauma patients, anyone with facial trauma, or certainly a basilar skull fracture or a cribriform plate fracture. These would be contraindicated in. But generally, I just recommend you to follow your agency's protocols and indications or contraindications to the use of the NPA or OPA. As far as insertion goes, after you've assessed your patient and determined the need for the NPA, and you've properly sized and lubricated it with a water-soluble lubricant, you're going to insert the device with the bevel tip towards the patient's septum. So these are generally designed to be put into the patient's nostril with the bevel tip facing the septum. Now, depending on what side it is, you may have to rotate this around to facilitate its passage. And you're just going to use gentle pressure, and if there's any resistance, you want to stop. But just use gentle pressure, and it should slide in quite easily. And then you just want to monitor your patient after you've placed it for their tolerance and airway patency. Like I said, it's not become an obstruction in and of itself. So that's just a quick overview of the NPA. Let's turn our attention now to the OPA, or the oropharyngeal airway, which is just our other airway adjunct here, used to facilitate airway patency and gas exchange, but is predominantly, well, specifically is used for our unconscious patient, one that no longer has a gag reflex. And this is important because we don't want to put this oropharyngeal airway into a patient who has a gag reflex, which may stimulate vomiting and result in aspiration. But as you look at the oropharyngeal airway, the anatomy of it, you can tell just by the contour of it how it's designed to fit over the soft tissue in the tongue and displace that tongue forward from the posterior pharyngeal wall and improve airway patency. The anatomy on this one, as you look, this outer portion here is called the flange, and it rests against the lips or teeth and just prevents it from, once again, migrating further into the airway. The body, which is the contact surface, which I alluded to, you can kind of tell in its unique design and shape to displace that tongue forward. And then, of course, the distal tip. This is just the terminating portion of the OPA. And then, of course, there's a channel through the center through which the gas can pass through, and you can even suction through like the NPA. Contraindications, just be familiar with that patients, as I mentioned, with an intact gag reflex, patients with facial trauma or disrupted anatomy that will prevent this from seating properly, in which case then this itself may become an obstruction to the patient's airway. Certainly if there are foreign bodies in the oral cavity, we want to remove those before inserting these. And once again, just follow your agency's guidelines on the proper use of the NPA and OPA. Now, when it comes to insertion of an OPA, there's a couple basic technique or approaches to how to insert these devices. And the first most common one is that when you open the patient's mouth and you insert this, you insert it kind of upside down. And the reason for this is you're going to try to move this around the tongue. And once you get past part of the tongue and that hard palate, you're actually going to rotate it midway through so it sits properly in the airway. Now, there is a somewhat contraindication in using this in peds because there is, well, I haven't experienced it, there is a thought that it can cause soft tissue injury to that soft palate and bleeding, so it's not recommended that this technique is used in pediatrics. But there is a second alternate technique which I really like, and that is using like a tongue depressor or even a rigid suction catheter. I have one here, and I will actually use this to physically displace the tongue and the soft tissue, and now I can actually insert this straight on the patient over there without risk of causing any soft tissue injury. So whether you use a rigid suction catheter like I have here, or a tongue depressor, or possibly even a laryngoscope blade, you can directly apply this straight in without having to rotate it. So there you have it, folks. These are just a couple examples of oropharyngeal airways, nasopharyngeal airways, and the basic components. I hope this has helped, and we'll see you next time. Bye for now. Okay, folks, so I'm just going to quickly demonstrate what we'd already talked about and discussed regarding the oropharyngeal and nasopharyngeal airway adjuncts. Let's start with the nasopharyngeal airway, and I have one here, and I have some lube as well, so I normally lubricate this, but I want to make sure I size it, and we talked about sizing it from the nair to the ear, so it's pretty close. And I'm going to put the bevel towards the septum, so I've lubed it. I've got my patient in the proper position. I've inspected the airway, and there's no contraindications to placing it. So I'm going to gently slide this in. Now this is a mannequin, so sometimes this doesn't work as well, but should slide in gently. The patient tolerate it. Now I have my NPA in place. I can look for my unconscious patient to place an OPA. Now there are a couple techniques we talked about for OPA placement. One is without any airway adjunct and the patient is unconscious, we can insert this device backwards. And what we do, we insert it, and once we get around the tongue, we're going to rotate it 180 degrees to sit on the teeth here. Now, that's one technique. Another technique I really like is the use of either a tongue blade, or I've even used my suction catheter before. Without having to turn it at all, I can just softly displace the tongue, and that really facilitates sliding in my oropharyngeal airway. Now again, just make sure that when you use your oropharyngeal airway, you're sizing it for each patient. It should be from the corner of the mouth to about the angle of the jaw for the patient. If it's improperly seated, it actually can become detrimental, as it can worsen obstructions and make it more difficult to ventilate your patient. So again, having something like a tongue blade or suction catheter, I can just slide this in real easily. That's it.